Hello friends, this is Dr. Ganga, your nephrology educator at Prep Ladder. Today let us learn about focal segmental glomerulosclerosis or FSGS. So we are going to learn this topic under the following headings. First, we are going to see what is the definition of the disease, then what is the etiology, pathogenesis, clinical features, what is the pathology, under pathology what are the types, what is the difference between primary and secondary FSGS, what is the natural history and prognosis, treatment, followed by what will happen when we transplant a patient who goes into ESRD because of FSGS. And finally, we'll end it with quick revision, which is nothing but the important points which has been asked in the previous exam that has been revised. So, if just before the exam, just skip to that section and go through, it will help you in revising easily. Now, let us start. First, what is the definition? See, it is basically histological diagnosis. Like they say, it is focal, as in, if you take this as the light microscopic section, you will see many glomerulus, right? For example, this section has 3 glomeruli. So, only few glomeruli will get affected. So, if you take 4, probably only 2 glomeruli will get affected. So, that is called as focal. Now, what is segmental? Only a segment of each glomerulus will get affected. First, only few glomerulus will get affected. That is focal. Segmental is only a segment of each glomerulus will get affected. So, that is called as segmental. Okay. So, what happens? Focal segmental glomerulo. That means the glomerulus undergoes sclerosis. Now, like I said, this is a histological pattern and there are multiple causes for this classified as primary and secondary. So, this is about the definition of the disease. Now, etiology, this huge table, it's actually pretty simple. So, let me just go through this table and make you understand. First, you classify this into primary and secondary, right? Like any other classification. First, you classify this into primary. Then you classify this into secondary. Now, coming to primary, which is also idiopathic, that is, no known or available cause will be detected. So, this will be probably because of circulating permeability factors, right? So, there will be some circulating factors which is increasing the permeability of the glomerular basement membrane and causing proteinuria and FSGS. Secondary FSGS. Secondary FSGS has multiple causes. So, the major sections are, first is genetic, like in anything else. Then infections, that is virus associated, drugs induced, mediated by adaptive structural functional response to reduced renal mass. So, fourth section, just remember when the whole renal mass gets reduced. And fifth is when there is initially normal renal mass. Okay. So, secondary are divided into 5 sections. What are these 5 sections? First is genetic, like any other cause. Second is when there is infection, that is virus. Third is drugs. Fourth is when there is reduced renal mass because of the structural and functional adaptation the other kidney has to undergo. That will lead to FSGS. Fifth is something that starts with a normal renal mass but again becomes into FSGS. So, FSGS seems to be like an end result of many insult to the kidney. Whatever is the reason, all those insults to the kidney going into glomerulosclerosis. Okay. Now, coming to the familial or genetic cause. This I'll deal with in detail when I talk about in the chapter of inherited diseases causing FSGS. So, first is mutation in nephrin, NPHS1, mutation in podosin, NPHS2, mutation in actin, ACTN4, mutation in TRP6 channel, mutation in WT1 channel, mutation in inverted formin 2, phospholipase and APOL1. So, all these things. So, I'll get to this in detail in that chapter also. You don't have to worry about it. Then coming to virus associated. So, you name it, any virus can cause collapsing nephropathy, including COVID. There are case reports of COVID also causing collapsing nephropathy. Okay. So, collapsing nephropathy or FSGS. So, here the important ones are listed, which is HIV, parvovirus. Here the important ones are listed like HIV, parvovirus, SV40 and cytomegalovirus. So, of this important one is HIV and CMV. Okay. Now drug induced. There are many drugs which can cause. I used to use a mnemonic for my exam to remember that. The mnemonic is hip sale. Okay. So what is this? H is heroin, I is interferon, P is pamidronate, S is sirolimus, A is anabolic steroid, and L is lithium. Okay. So this is the mnemonic I used to use. I know it doesn't make much sense, but I had revised it many times so that the mnemonic also I remembered. Okay. So if you would like to, you can use this mnemonic to remember. That is hip sale, that is heroin, interferon, pamidronate, sirolimus, anabolic steroid, and lithium. Apart from this, tyrosine kinase inhibitors are also used. So these are the drugs. Now, fourth thing is the diseases which are mediated by adaptive structural functional responses like reduced renal mass. So when the renal mass reduces, which could be those conditions? Oligomeganephronia, that is by birth when there is less number of nephrons, okay, or less kidney mass. Very low birth weight, because they also will have less kidney mass. Unilateral renal agenesis. So here I want you to notice that very low birth weight itself is a risk factor for renal disease, which is FSGS. Third is unilateral renal agenesis, that is only one kidney is available. Or renal dysplasia, again when some part of the kidney is only available. Or reflux nephropathy. Or there is cortical necrosis, surgical renal ablation, chronic allograft nephropathy, and any advanced renal disease with reduction in functioning nephrons. So any advanced disease because of any cause. So basically when the kidney mass is reduced, which can be because of any cause, you don't have to remember these by heart, because if you read it in the options also you will know. Like for example, if it's cortical necrosis, renal abrasion, reflux nephropathy, very low birth weight, oligomeganephronia. So all these conditions, the kidney mass reduces, right? And the single kidney that is available undergoes compensatory hypertrophy and hyperfiltration. So this pressure is what is going to lead to FSGS. Then conditions with initially normal renal mass, but later will turn to FSGS. These are hypertension, atheroemboli or other acute vaso-occlusive process, obesity, which is very, very important, increased lean body mass, cyanotic congenital heart disease, and sickle cell anemia. So in this, important to remember is hypertension and obesity and increased lean body mass. Like this, people going to gym and using anabolic steroids and high protein diet to increase their muscle mass. So they are an important risk factor for FSGS. Okay, so these are the causes for primary and secondary FSGS. Now coming to the pathogenesis. See, like in minimal change disease, we know that the glomerular basement membrane or the podocyte is going to collapse. Okay. So, coming to the podocyte, which has the actin cytoskeleton. So, if you go back to the chapter on minimal change disease, you will see that. So, this actin cytoskeleton has a problem. Okay. So, because of that problem, what happens? The food process. So, this is the glomerular basement membrane. Assume this is the podocyte, and which has the actin cytoskeleton. If this collapses, what is going to happen? The food process will get effaced. Okay. The food process will get effaced and it will form a single thing like this. And eventually this effaced food process is going to detach from the GBM. Okay. So basically it is disease which is affecting the podocyte. That is why MCD and FSGS are coined under the broad terminology called podocytopathies. So if a question about podocytopathy is coming, that means they're intending to ask about MCD or FSGS. Now, why this happens? Why this disruption in actin happens? So there are theories about this. The important theory is there are circulating permeability factors. So get that term. Okay, circulating. So it's in the blood. Permeability factor. That means it is increasing the permeability of the protein through the glomerular basement membrane, right? So which is the circulating permeability factor? It's called SUPAR. Okay, that is soluble urokinase plasminogen activator receptor. So this is the circulating permeability factor. So this circulating permeability factor alters the membrane permeability. So how they detected that this circulating factor is important is in post-transplant, when patient has recurrence of FSGS, By doing plasmapheresis and removing the circulating permeability factor, it was found that the patient is going into remission. So because of this, it was found that SUPAR is the circulating permeability factor which is important in the pathogenesis of FSGS. Now, coming to the type of proteinuria. In MCD, we know that the proteinuria was selective. Here it is non-selective proteinuria. Why is the difference? In MCD, there is no detachment of the podocyte. There is effacement, but it does not detach. But here, the podocyte gets effaced and it is detached. So, large amount of proteinuria, not just albumin. So, it is because of detachment of podocytes. And in secondary FSGS, what happens? Like, for example, if there is reduced renal mass, you assume, there's going to be glomerulomegaly, because I told whatever kidney is left out, that is going to function more. So, by functioning more, what is going to happen? It is going to hypertrophy, right? So, there's going to be glomerulomegaly, glomerular hyperfiltration, and glomerular hypertension, and then finally leading to sclerosis. So, first it becomes big, that is glomerulomegaly. Then once it becomes big, it's going to filter more, right? So, hyperfiltration. Then once it is going to hyperfilter, the pressures are going to be high inside that. So, that is hypertension. So, once all this happens, the chronic damage is what leads to sclerosis. Okay, this is in secondary. This is under genetic, there is an important variant, that is APOL1 gene variant. Okay, so this APOL1 is the one which is known to cause many kidney diseases. This just gene variation, whatever is there in African population to prevent against malaria, this is known to cause many kidney diseases, and these are 4 important kidney diseases. So this has been asked as a question, AIMS paper. So which are the diseases that causes APOL1 gene related diseases? So first is FSGS, HIVAN, lupus nephritis, and chronic hypertensive nephrosclerosis. See, FSGS and HIVAN is something that we already know is associated with APOL1. So here it is lupus nephritis and chronic hypertensive nephrosclerosis. So these two are the additional additions to this. Okay, so these 4 conditions you have to remember. Now, how structural maladaptation leads to FSGS? When there is reduction in nephron number, there is hemodynamic stress. Also, there is something called as obesity-related glomerulopathy. So, this is mostly seen in patients with metabolic syndrome, and the speciality of this is the podocyte effacement is not as much severe as in primary. Okay, I'll be dealing with this later also. And full nephrotic syndrome is not seen. So, patient progressing into ESRD is also very rare. So, patient progression to ESRD does not happen commonly in obesity-related glomerulopathy. So, this is important. Coming to the biopsy of secondary FSGS. Secondary FSGS is going to have glomerulomegaly. This we already discussed what is the reason. And there's going to be perihilar lesions. This we'll discuss in the coming pathology. Coming to the epidemiology of FSGS, males are generally affected more than females, and ESRD is seen more in males when compared to females. Now, clinical features. Okay, so 50 to 70% of patients present as nephrotic syndrome. So, nephrotic syndrome is not 100% in this disease. 50 to 70% present as nephrotic syndrome. Hypertension is seen in most patients, unlike in minimal change disease. So, nephrotic syndrome with hypertension generally are differential comes to FSGS and membranous nephropathy. Okay, microhematuria is also seen in 30 to 75%. So you might find some 8 or 10 RBCs in the urine routine report, and it is not shocking. Okay, decreased GFR is seen in 20 to 50% of patients. So creatinine will be elevated in approximately 50%. So these are patients who are mostly nephrotic, around 50 to 70%. Who come with elevated blood pressure and elevated creatinine, who can have few RBCs in the urine. So while doing the complements, these patients are going to have normal complements because this is not a immune complex mediated disease, whereas it's because of increased circulating permeability factor. Now, there are different types of classification of FSGS. I'll come to it in the next slide, but each type has a different presentation. Okay. For example, tip lesion has something like a minimal change disease, that is abrupt onset of nephrotic syndrome and severe edema and all that. Then there is a variant called cellular variant also, which presents as full-blown nephrotic syndrome and higher incidence of nephrotic presentation. Whereas collapsing variant mainly presents with increased creatinine. Okay, so as we go on, I'll discuss more about this. So pathology, to detect the pathology, that is to detect the pathology of FSGS, because it is focal and segmental, we don't require just the 8 to 10 glomeruli which is required for other disease diagnosis. Here we require 20 gloms. Okay, so this has been asked as a question multiple times. You should know that 20 gloms are minimal, or glomeruli are minimal required to make the diagnosis of FSGS. And in early disease, this FSGS is going to affect only the deep juxtamedullary glomeruli. If this is the medulla, the glomeruli that are here are the only ones that are going to be affected. So here, if you're going to totally miss the diagnosis of FSGS. Okay. Now, based on the morphology, these are classified into 5 types. This is called as Columbia classification. Okay, here I would like you to recollect that Oxford classification was used for MEST scoring in IgA nephropathy. This is the second type of classification, which is Columbia classification. This name also, it's normally not mentioned in textbooks, but it has been asked in exam that Columbia classification is used for what? Okay. So based on this, it is classified into 5 types. First is not otherwise specified, that if it does not fall into any of these category, it becomes not otherwise specified. So if this is a glomerulus, we know that here will be the hilum and here will be the tip, okay, where the tubule is there. So for one variant can be perihilar, that is if the perihilar region is involved. The other can be the tip lesion, that is if the tubular pole is involved. Another one is cellular, where the inside endothelium and the mesangium is involved. The other variant is collapsing, when all these collapses. So simple, it is perihilar, tip, cellular or collapsing. So these are the 4 important variants. So if none of these can be diagnosed, then it is FSGS NOS. Okay. There's also a type called FSGS unclassified, which is not a pathological type, but like how primary and secondary, there's one type called FSGS unclassified. So this is come in the latest 2021 guidelines. I'll be talking about it when I discuss the KDIGO guidelines, the chapter on KDIGO guidelines, which is management of nephrotic syndrome. Okay, so how do we classify these lesions? So what is perihilar? If more than 50% of glomeruli with lesion shows hyalinosis and sclerosis in perihilar region. So for example, you take this as the LM section having 4 glomeruli, okay. So out of this, if 3 glomeruli are showing perihilar lesion, that is more than 50% of the glomeruli shows perihilar lesion, then it is called as perihilar variant. What is cellular variant? Obviously, we know that the glomerulus will have endothelium, which will have endothelial cells, right? So if there is endocapillary hypercellularity, that is hypercellularity here, then it is called as cellular variant. What is collapsing? For collapsing, only one glomerulus is required. You don't require more than that. So if one glomeruli show global collapse and visceral podocyte hypertrophy and hyperplasia. So if this is the glomeruli and here is the endothelium like this, and if this is totally collapsed, okay, collapse means it's shrunk, and the visceral podocyte which is around it has undergone hypertrophy like this. Generally, we know crescents are formed by the parietal cells, right? So here visceral podocyte undergoes hypertrophy, then it is called as collapsing variant. Then coming to the tip variant. Tip variant is when the lesions are in the tubular pole. Here the number of this thing is not important, but the lesions will generally be in the tubular pole. Now coming to FSGS NOS. This is the most frequently diagnosed type of FSGS. It can come in primary form, it can come in secondary, or it can be genetic also. So what happens is, there's accumulation of this is the glomerulus, there's accumulation of extracellular matrix, and here there will be capillaries under this, so that will get occluded. Once it gets occluded, so there is lot of segmental solidification, the glomerular basement membrane here will wrinkle because underlying that part is sclerose, right? So imagine something is getting sclerose. This will wrinkle. It will not stay stiff like this. It will wrinkle. And finally, because this wrinkles here, whatever is the overlying podocyte is there, that would have collapsed and detached. So this is what happens in FSGS NOS. Okay. Now, once that happens, here whatever this visceral podocytes are there, they undergo hypertrophy. So this is the GBM. Whatever the FS visceral podocytes are there, they undergo hypertrophy and they form something called as a cellular cap. Okay, so this is a cellular cap and there will be significant interstitial fibrosis and tubular atrophy. Okay, so this is the picture. So here you can see that there is segmental sclerosis, that is solidification. Here you can see this ones. Okay, so here you can see that these ones are the podocytes that are hypertrophied. Here, if you can see here, the podocytes that are hypertrophied and become hyperplastic. Okay, so that this looks like a small cap, so that becomes a cellular cap. If you go to immunofluorescence, there will be IgM and C3 deposit, which is mostly passive trapping. Now, when you go to the electron microscopic appearance, there is going to be this electron, there is going to be the extracellular matrix that are deposited. When something deposits, what happens? The blood vessels or capillaries become narrow. The GBM overlying it will retract. The podocyte overlying that will detach and efface. Okay, so these are the things that we discussed till now. That is what you are going to find in electron microscopy. So this is the first type, that is FSGS NOS. Coming to the perihilar region. So this is where the blood vessels are coming. So you can see the perihilar region. So here is the sclerosis. Okay. So what happens whenever there is reflex dilatation of the afferent arteriole? So if this is the glomerulus, this is the afferent and this is the efferent. Okay. So when there is reflex dilatation of this, what is going to happen? There is going to be greater filtration pressure here at the vascular pole. So this is going to lead to the sclerosis. But here, since it's a localized thing, the effacement is going to be mild and whatever surrounding podocytes are there, they are not going to undergo much hypertrophy, unlike in FSGS NOS. Okay. So it's basically a milder lesion, that is perihilar. That is why this is mostly seen in secondary and the patients generally have non-nephrotic range proteinuria and generally they do not progress to ESRD. Okay, so these are the characteristic features of secondary FSGS causing perihilar lesion. Next, coming to cellular variant. Cellular variant is mostly primary. Okay, that is no cause can be identified. There is going to be endocapillary proliferation. There is going to be some hypercellularity and it's going to invite some leukocytes, debris, foam cells. Okay. And because there is inflammation or hypercellularity, the overlying podocytes are going to hypertrophy. Okay, so the overlying podocytes, when it hypertrophy, it forms something like a pseudocrescents. Okay, so all this is because of the visceral podocyte, like how we read cellular cap in FSGS NOS. This is another type, which is cellular variant. So there is so much cells. You remember there is going to be proliferation. It's going to form a pseudo crescent. Okay. And food process effacement is generally severe. So this is seen in primary FSGS. Now coming to the collapsing variant, which is a very important thing. Generally, it is required that only one glomerulus with collapse is sufficient to make this diagnosis. Okay. And once it collapses, there is going to be overlying hypertrophy and hyperplasia of the visceral epithelial cell. So far among the lesions that we studied, only perihilar lesion is not going to have podocyte, overlying podocyte, hypertrophy and hyperplasia. Okay. So what happens? The tubules also that are there are dilated and they have some microcysts and they'll contain proteinaceous cast, because what is going to happen? All the proteinuria that is going, it's going from the glomerulus into the tubule, right? So the tubule will reabsorb this protein and cause some cast. Okay. And electron microscopy will show severe food process effacement. Now, it's very important to remember the causes of collapsing nephropathy. First is virus, drugs, autoimmune. So these are the three major classifications. Under virus, it is HIV and parvo. Okay. So these two are the important viruses that can cause collapsing glomerulopathy. Then coming to drugs, it can be interferon therapy, it can be tyrosine kinase inhibitor, and it can be pamidronate. So if you remember the hip sale mnemonic, so out of the 3 drugs, okay, so interferon, tyrosine kinase inhibitors and pamidronate. Then coming to autoimmune, which can be lupus or hemophagocytic syndrome. Okay. So the important causes of collapsing variant of FSGS is, you can classify it into virus, drugs and autoimmune. Virus is HIV and parvovirus. Drugs are interferons, pamidronate and tyrosine kinase inhibitors. And the autoimmune conditions are lupus podocytopathy and hemophagocytic syndrome. Okay. Now, these will also have tubulo-reticular inclusions in electron microscopy. So, the conditions that are causing tubulo-reticular inclusions in electron microscopy is also a question. See, all these are fact-based questions. There's nothing much to remember. These tubulo-reticular inclusions are nothing but in the endoplasmic reticulum, there is going to be interferon footprints. Okay, so these interferons are going to appear like tubulo-reticular inclusions when seen in electron microscopy. So anything that can produce increased interferons like HIV or lupus or interferon therapy per se can lead to this tubulo-reticular inclusions. That is, it's as simple as that. Okay. Now coming to the tip variant. Tip variant is only segmental lesion involving the tip domain. So what is the tip domain? The 25% of the tuft that is next to the proximal tubule. Okay, if there's a proximal tubule, the 25% of the tuft next to it is called as tip lesion. These lesions are generally segmental. It can be cellular or sclerosing, and foot process effacement is severe and it resembles MCD. So like we discussed, tip lesion means the tip of the glomerulus is involved. That is the 25% next to the proximal tubule. Okay. So this presents MCD clinically. Cellular lesions also will have nephrotic presentation, full-blown nephrotic presentation, and collapsing lesions will present with fallen GFR, right? So these are the important types. Now there are some other variants which are not very important. First is FSGS with diffuse mesangial hypercellularity. So we saw that generally mesangium is unaffected in FSGS, right? But here it can happen. So it's mostly seen in young children with generalized hypercellularity involving mesangium, endothelial, everything, and along with FSGS. So there is diffuse mesangial staining of IgM and variable staining of C3. So that is what is seen. And electron microscopy is going to cause extensive foot process effacement. So this will not fall into that category, which is causing that category of the condition. So electron microscopy shows extensive foot process effacement in this condition. Okay. Now next is C1q nephropathy. So we discussed this in MCD also, because this disease can have MCD or FSGS in biopsy. But the only finding is there is going to be C1q in the immunofluorescence. Okay, dominant mesangial staining of C1q. And other deposits are C3 and IgG. And electron microscopy is going to show electron dense deposits that are there in the paramesangial areas, which is actually the C1q along with foot process effacement. So there can be FSGS with some mesangial positivity, mesangial hypercellularity, and also C1q nephropathy. These two becomes variants. Okay. How will you differentiate between primary and secondary with respect to pathology? Clinically, we already know that these are going to have non-nephrotic proteinuria, and they generally do not progress to these are generally going to have non-nephrotic proteinuria, and they do not progress to ESRD. So there is going to be non-nephrotic proteinuria, and these patients generally do not progress to ESRD. This is the clinical feature. So how do we recognize pathologically? First of all, in secondary, the podocyte effacement is going to be less than 50% of total glomerular surface area. Whereas in primary, out of the total glomerular surface area, if this is one glomerulus, only less than 50% gets effaced in secondary. But repeat. If this is the glomerular surface area, only less than 50% gets effaced in secondary. However, in primary, there can be more than 50% effacement. That is 80 to 100% of the surface area also can get effaced. In HIV nephropathy, there is going to be tubular microcyst and tubuloreticular inclusion. In obesity related, we already discussed, there can be glomerulomegaly with perihilar lesion. These are the additional things that we are going to find. When there is loss of renal mass, like in oligomeganephronia or renal ablation, here there is going to be extensive interstitial fibrosis and tubular atrophy. There is going to be extensive interstitial fibrosis and tubular atrophy along with arteriosclerosis. Again, there is sickle cell disease where there can be capillary congestion and double contouring of the GBM, like in chronic TMA appearance. So, sickle cell nephropathy can cause that. Okay. So, these are the additional findings that we will see in secondary. So, most important here is you have to remember obesity related. That is what has been asked as a question multiple times. Okay. Now, coming to the natural history and prognosis of the disease. The unresponsive patients generally progress to ESRD in 5 to 20 years. That is the patients whose proteinuria remains to be nephrotic. And 50% among this become ESRD in 10 years itself. So, around most of these patients, unresponsive patients, progress to ESRD. It's like there is no escape for this. Okay. And what are the risk factors that show that ESRD or CKD is possible in these patients? We can classify based it on clinical features at the biopsy or clinical features during the disease course, or what is the pathology showing. Clinical features at biopsy is severity of nephrotic range proteinuria. So, more proteinuria, more is the chance of CKD, ESRD. Elevated serum creatinine, that is already significant renal function is lost. Or black race, because mostly they will have APOL1 gene related diseases. Okay. So, all these becomes the features at biopsy, that is more proteinuria, more creatinine, simple. Now, histopathologic features that indicates poor prognosis are collapsing variant, which is the worst prognosis. The variant with worst prognosis is collapsing. Otherwise, presence of IFTA, that is interstitial fibrosis and tubular atrophy, already indicating chronic disease. Now, clinical features during disease courses, failure to achieve partial or complete remission. So, we are treating and the patient is not going into remission is also indicating that the disease is going to be severe. Now, prognosis, the outcome is going to be best in TIP variant. That is only 6% goes to ESRD. Okay. Because remember, I told this clinically is like MCD, which again has excellent prognosis and is steroid responsive. So, this is going to be best in TIP variant. However, it is worst for collapsing FSGS, where 65% goes into ESRD. This is again important. You have to remember that the outcome is best for TIP variant, whereas it is worst for collapsing variant. Okay. Now, coming to the treatment. See, this is just an outline. I'll be talking about this in detail again while I go to the chapter of management of nephrotic syndrome as a whole. So, focus on this part there, but here it's just to get the names. So, if patient is having subnephrotic proteinuria without symptoms, it is BP control, AC inhibitor, ARB supportive therapy, therapy with statins, avoid high protein diet. Okay, so it is same. It is supportive therapy like in any other glomerular disease. If nephrotic syndrome is there, along with supportive therapy, you add steroid. 1 mg per kg per day. Minimum you try for 16 weeks. And then you try to taper it over 6 months. That is 1 mg per kg per day of prednisolone. Minimum which you try for 16 weeks. Okay. This is before calling the patient steroid resistant. And if they respond, you are going to taper it off and stop it by 6 months. Now, what will happen if the patient does not respond to this steroid therapy? You are going to consider CNI, which is cyclosporin and tacrolimus. So, don't worry about the dosage. I'll get to it. See, here they mentioned oral cyclophosphamide. This is from Fihali, okay? But right now in 2021 GN guidelines, oral cyclophosphamide is not mentioned in the treatment of SRNS, okay, or steroid resistant nephrotic syndrome. So, remember, this is there in the textbook. You might be reading only the textbook. When you go back to the guidelines, you might not get time to go back to the guidelines. So, if a question comes that which of these can be used in SRNS and cyclophosphamide is one of the option, you do not think that that can be used as a treatment. Okay, it should be cyclophosphamide should not be used in the treatment. Other option is MMF. It is used in a few places. MMF with high dose dexamethasone is considered in few places. So other treatments, like I told, calcineurin inhibitors, cyclosporin or tacrolimus, it is known to stabilize the actin cytoskeleton and hence it prevents proteinuria. Okay, MMF plus DEXA that I told, plasma exchange especially in post-transplant patients to remove the circulating permeability factors, that is SUPAR. Okay, that is soluble urokinase plasminogen activator receptor. Rituximab, abatacept and ACTH again does not have much evidence. Okay, so these three are considered in steroid resistant nephrotic syndrome. Now once these patients go into ESRD and we do transplantation, 30% of them have recurrence. I have dealt with this in detail in the chapter of recurrence of FSGS or recurrence of diseases post-transplantation. You can go and check it out there. But here just I'll give. So 30% of patients undergo recurrence. The risk factor of recurrence is if they had early onset disease, that is earlier in the childhood, and rapid course of renal failure, that is in less than 5 years they are progressing to ESRD and proteinuria was very severe to begin with, or they already have lost a prior allograft to recurrence. This has the highest risk. Okay, so already one graft is gone because of FSGS. One kidney that is transplanted is gone because of FSGS. This forms the highest risk. So the four important risk factors are: one is early onset of the disease, or rapid progression to ESRD, or very severe proteinuria, and if an allograft is lost to recurrence. Okay, so this is about the risk factors that is causing that will help us in predicting the recurrence of FSGS post transplantation. Now coming to the quick revision section, drugs causing secondary FSGS. So I told to remember by the mnemonic HIP, SAIL. So that becomes heroin, interferon, pamidronate, sirolimus, anabolic steroids, lithium, and apart from these 6 drugs, tyrosine kinase inhibitors. Okay, so circulating permeability factor in FSGS, we know it is SUPAR, and this is more so in post-transplant population. This has been proven. Okay, so SUPAR is soluble urokinase plasminogen activator receptor. Then APOL1 nephropathy, we know it is mostly seen in black race, can cause 4 diseases with respect to kidney. One is collapsing FSGS. Second one is HIVA or HIV associated nephropathy. Third is lupus podocytopathy. And fourth is chronic hypertensive nephrosclerosis. Next is presentation of various types of nephrotic syndromes with respect to FSGS. That is, tip lesion mostly presents as MCD. The cellular variant also presents as nephrotic syndrome, full-blown nephrotic syndrome. Collapsing variant presents with reduced GFR. Okay. The number of glomeruli that is required to diagnose FSGS is 20. Okay, 20 glomeruli are required to diagnose FSGS. So the causes of collapsing variant can be classified into infection, drugs, and autoimmune. Okay, among infection it is HIV and parvo. Among drugs, it is interferon therapy, pamidronate therapy, and tyrosine kinase inhibitors. Among autoimmune, it is lupus podocytopathy and hemophagocytic syndrome. Okay. Primary versus secondary FSGS. We know that secondary FSGS, less than 50% of podocytes are going to be effaced. So proteinuria is going to be non-nephrotic, that is, it is going to be less than nephrotic range. So ESRD is going to be late. And specifically in obesity related glomerulopathy, we are going to see that the lesions are going to be mostly perihilar lesions and there is going to be glomerulomegaly. Okay, so these are the features that you have to remember. Next, coming to recurrence post-transplantation, 30% of patients who had ESRD because of FSGS recur post-transplantation, and the risk factors are going to be early onset of the disease. After onset, it is progress, early progress to CKD ESRD. And third thing is, if they are going to have first graft which is lost because of FSGS. Okay, so this is the most important risk factor or the highest. Okay, and fourth is if they're going to have very severe proteinuria. So the treatment for this will be plasmapheresis to remove the supar factor. So this is again, like I said, I have discussed this in recurrence in post-transplantation, that chapter. Okay, you can go and refer there. Thank you friends. I hope I have helped you in understanding this chapter. Bye-bye.